Can be vomiting, diarrhea, fever, burns, tachypnea, which you see all that in front of you on your PowerPoint. And you're probably wondering, you're probably thinking a burning idea in the back of your mind is, why isn't diabetic ketoacidosis also on this list? And the answer is, you're right, it should be, so write it in, please. Now, I want to talk about how, since we're talking about dehydration, I want to talk about why infants are more vulnerable to dehydration. And part of that is because they have a relatively greater body surface area. And you might be thinking, how can an infant have a greater body surface area? And the answer to that is that they don't really have a greater body surface area. It's relative. And so what the way I try to display that, give you an example of that is, let's picture for a minute if I had two clay balls and they're the same. So I'm going to put one down on the counter and the other one I'm going to take and I'm going to roll it into a long snake. And then I'm going to put that on the counter. Then I'm going to go away until 10 o'clock tomorrow morning and I'm going to come back. And what am I going to see? What will I see?
The round one is going to stay wet and the long one is going to stay dry.
The round one will stay wetter, the long one will dry out. And why will it dry out?
Because the surface area is elongated.
Because it has more surface area. And it can lose the moisture out of the surface area more easily because there's more of it. That's like insensible loss. Okay, so that's kind of like how an infant is. They have more surface area per body mass. So they are more vulnerable to dehydration. Questions on that? Okay, another reason that they're more vulnerable to dehydration is that they have a higher basic metabolic rate. And they have to because they have all that growth and development they're going through. And in 6 months, they're going to double their size. In a year, they're going to triple their size. So they have a lot of metabolic activity going on. And that increases their heat production. It increases their insensible losses, insensible fluid losses. So that's a second reason that infants are more vulnerable to dehydration. A third reason is that they have immature kidneys. And their kidneys can't concentrate urine the way ours do. And we talked about in another lecture how if you go on a hike on a very hot day, you forget to bring your water bottle, when you're done with your hike, if you go and urinate, that urine is going to look very dark and concentrated. Because your body says, wait, I have to conserve fluid here. I'm losing, I'm perspiring and I'm very hot and I need some more hydration. I don't have my water bottle. So the kidneys say, I'm going to hold on to the water. I'm going to concentrate the urine when it comes through that loop of Henle. And I'm going to put out a concentrated urine so that I can hold the water. Well, with an infant, their kidneys are immature and they just can't do that. So that's another reason that they're more vulnerable to dehydration. A fourth reason I say is because of all the first three reasons, they have higher fluid requirements. They have to ingest and excrete more fluid per kilogram than older children and adults. So they're more vulnerable. Additionally, I want to say that greater than half their total body water is extracellular. Now let's recall back that we know that our fluid is either extracellular or intracellular. When we lose fluid out of our body, which compartment do we lose it out of? Our intracellular compartment or our extracellular compartment? Extra. I heard extra. And the reason why we lose it out of our extracellular compartment is because our intracellular water is kind of protected. It's packed in the cells. The extracellular water is vulnerable to dehydration or urination or however we lose fluid. Now the catch is that once you lose enough fluid out of your extracellular compartment, the water in your cells says, wait, why do you balance here? It's so, we have a lower concentration here of solutes. We've got a lot of fluid in the cells. They're getting kind of concentrated extracellularly. But the water says, I'm just going to pass over through the cell membrane and I'm going to go into the extracellular compartment because then we'd have balance. So now your fluid from your intracellular compartment has become vulnerable to the outside world. It's in the extracellular compartment. And then we can lose that. So now you have less fluid in your intracellular and extracellular compartment. Your next box on the PowerPoint says assess the extent of dehydration. So I want you to look at this handout. Everybody have one? I want you to look in that for a page that looks like this on dehydration. This is just a matching game that I made you from StudyStacks. Have you guys ever heard of StudyStacks online? It's like learning games. And I figured out that the only real learning game you can do with this material on that site is matching, so I made you some matching. But look on another page that has this comparison chart for dehydration. And let's talk through it. It has the 3 levels of dehydration: mild, moderate, and severe. When someone is mildly dehydrated, they're pretty alert with regard to their mental status. But when they're moderately dehydrated, they might become listless. And when they're severely dehydrated, they can be alert, but they could also be comatose. So they could be anywhere on the spectrum with regard to their mental status. Talking about infants, you talk about fontanelles. We look at the fontanelles, and we see for a mildly dehydrated infant, they're soft and flat. For a moderately dehydrated infant, we see they're sunken, and same thing with severely dehydrated. Eyes, straightforward. Oral mucosa, straightforward. Skin turgor, I know you learned about that in Nursing 1. Heart rate. Let's talk about heart rate, which of course, as you know, is pulse. For mildly dehydrated, it's around normal. It can be increased for moderate dehydration. Why does the heart rate go up when somebody is moderately dehydrated?
Just to pump up fluid.
It's a compensation. It's a compensation. It's the heart saying, oh, I'll just pump faster, and that will get this smaller amount of fluid around. So that's what is going on there. Now you can see for severe dehydration that the heart rate is increased, progressing to bradycardia. Let me just say for the increase, the tachycardia is usually the first sign of dehydration. So, we see increase progressing to dehydration. Progressing to bradycardia. Now, why do you think it says bradycardia there? Why would it be increased progressing to bradycardia when somebody is severely dehydrated?
Fluid, so the body can.
What did you say? Yes. But shock. We're thinking this person might be going into hypovolemic shock. And so then the body says, okay, I'm going to shut down here. I can just do a brady rhythm. They can progress to a hypovolemic shock. Very good. Blood pressure can be, they can get hypotensive in severe dehydration. In extremities, you can see their capillary refill slow down. In severely dehydrated individuals, you can see it go to over 4 seconds. With regard to urine output, of course, you're going to progress toward oliguria. Now, I want you to add at the bottom a parameter under urine output. I want you to write thirst. And in the categories mild, moderate, and severe, I want you to write slight, moderate, and intense. want you to write behavior. I hope this is correct. That's all I have.
I'll share with Terry.
Here's one. Who's this?
I think it's from us.
That's not CSO. Oh, sure. I don't have another one here.
That's all right.
Which one do you take here?
I gave him, he did.
I don't think I have another one. So under that, write behavior. And for mild, you can put that it's normal. For moderate, you can put that it's irritable. And for severe, you can put hyper-irritable to lethargic. And one more category under behavior, write tears. And you can write present, decreased, or absent. Now, when we go back to the PowerPoint page at the bottom, it does say labs on that bottom of that list. And I want you to put hematocrit. And what do you think happens to the hematocrit when someone's dehydrated?
What's that?
It goes up. It goes up. And the other thing you can there. You could also put that the specific gravity of urine also goes up. Let's go to the next box, which is diarrhea. Everybody always wants to talk about diarrhea as much as they can, so you're in luck. We're going to talk about diarrhea for a while here. There's a couple kinds of diarrhea. There is acute and chronic diarrhea. For acute diarrhea, there are various causes. There's an infectious agent in the gut, such as a virus, and there's one virus called do you guys know what the most important GI virus is in babies? It's the rotavirus, that's right. The rotavirus is the most important cause of serious gastroenteritis among children, ROTA virus. I think if you look at it under a microscope, it looks like a wheel, and that's why they call it a rotavirus, because it looks like that. So it's the most important serious gastroenteritis among children. It's also a significant nosocomial pathogen. Nosocomial, does everyone know what that means? And it is most severe between 3 months and 24 months of age. Any comments about that? 3 months to 24 months. Anything you want to say about that? Like, why? Somebody want to say why? 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 We have 3 months to 24 months. What's the why? Their immune system. Their immune system, say more about that.
So, in the younger stages, they have immature immune systems, basically, right?
Right.
Whereas when they get to the 24 months, their own immune system begins to kick in.
They're at 24 months, their immune system says, I get it. I can do my job more optimally. But what happens between birth and 3 months?
More stuff is introduced into the body.
Anything else? It's passive immunity that they really got from the mom, right? From when they were gestating. Of course, when they're being breastfed, they are going to have that for longer. So what is the root? How do people get gastroenteritis like the virus is? How do they get that? Oral. Yeah, it's the oral fecal route. Gross as it sounds, that's how people get it. So because of that, we want to really emphasize hand washing. Other ways that people can get infectious agents and that cause diarrhea, they can get bacteria such as Shigella or Salmonella or E. coli. Shigella. Salmonella and E. coli. And a third type of infectious agent in the gut is parasites. And the parasite that I mentioned in the lecture is Giardia. Giardia. How do people get Giardia? Anybody know? Where's Giardia found? Contaminated water. What kind of water? In the stream, right. It's outside in wildlife. That's why we don't go into that beautiful running stream or brook and drink the water, because it could have salmon, it could have Giardia in it. And when my son was a little boy, when he was in preschool, they used to walk him over to this lovely spot with arches and ducks and geese. And it was all lovely except for he got Giardia from there. And at the time, the providers were not culturing for it. And it took them a long time to culture for it. And we finally found out he had Giardia. And the diarrhea was so bad that he would have diarrhea while I was changing his diaper. He's a young adult now. So I'm sure he's really happy that I talk about his diarrhea in class. Maybe you'll meet him at graduation, and you'll know. But anyway, what happened was, I was given an antibiotic that was liquid, and I had to put it in a syringe without a needle, and then put it between his teeth, gums, and his cheek, right, to get him to take it. And something that you can't do in clinical is I couldn't really get him to stop moving around, so I would actually lie on him and hold his head and put it, and he'd be like, no, and then I'd have to be like, swallow, swallow, and finally he would, and he fought me through the whole thing. But it did work, thank goodness, because that was a terrible experience for all of us. And of course, he doesn't remember it, but I get to remember it. He was like 2.
So Giardia is a bacteria, right?
Say it again?
Giardia is a bacteria, right?
Parasite.
So we can use antibiotics for that.
Yes. I've been flagell we gave for that. So, another way that people get diarrhea is sometimes people get diarrhea when they have a URI or a UTI. Sometimes some people's bodies just get diarrhea from those things. We also sometimes get diarrhea when we take an antibiotic. And that is probably something you knew. Because antibiotics, even though they get the bad guys, they also can get the good guys that are protecting us. And so we end up with diarrhea. That's why we give probiotics when people are on antibiotics, or tell them to have yogurt. What is the organism that people get when they're in the hospital and they're on antibiotics? It's C. diff, right? So, in addition to that, when people are on laxatives, they can get diarrhea. Acute diarrhea is usually self-limited, less than 14 days. It may subside without any treatment if dehydration does not occur. Acute diarrhea has increased frequency in infants and increased severity in infants. And that is because they have been exposed to less pathogens and they have less acquired protective antibodies. The lining of their gut is more immature and doesn't know what to screen out and what to take in. So they are more vulnerable to acute diarrhea. Then there's chronic diarrhea. Chronic diarrhea lasts more than 14 days. It can be due to malabsorption syndromes, such as celiac disease, which we will talk about more in this lecture. But people who have celiac disease cannot process gluten, which is found in wheat. Another cause of chronic diarrhea is inflammatory bowel disease, which is Crohn's or ulcerative colitis. Crohn's, C-R-O-H-N-S. And that's just inflammation of the gut for no good reason. That's a Nursing 3 topic. You'll get more about that in Nursing 3. This is where I like to touch upon like a concept. Because when people get inflammation in a part of their body for no good reason, with no infectious organism, we tend to give them steroids because that's an anti-inflammatory, remember? So when we have like eczema, we put steroids cream on the skin. When we have nephrotic syndrome, which you've already learned about, people take steroids because that's inflammation on the glomerular basement membrane for no reason. When people have a hyper-reactive immune system in their lungs, that's asthma, and we have them inhale steroids. So, and here we are with Crohn's and ulcerative colitis, where you have inflammation in the gut, and we give them steroids. So I just want you to kind of see that theme as kind of a concept in medicine and nursing. Additionally, people get diarrhea when they have an immune deficiency, such as HIV. People get diarrhea from food allergies and lactose intolerance. So write this down, it's not in a box. The most serious and immediate physiologic consequence. The most serious and immediate physiologic disturbances associated with severe diarrhea. The most serious and immediate physiologic disturbances associated with severe diarrhea are dehydration. That was number 1. Number 2 is acid-base disturbances, and that they get acidosis because they lose bicarb in diarrhea. The second one is acid-base disturbances, like an acidosis, because they lose bicarb in diarrhea. And number 3 is shock. If dehydration progresses, they get shock. And that would be if it goes to impaired circulatory status. Questions? I want to go to the next box, and I just want to mention that some of the etiologic agents of diarrhea will secrete an enterotoxin that will become toxic to the mucosa and cause diarrhea. Some of them will just invade and penetrate the mucosa and cause diarrhea and perhaps a systemic illness with it. E. coli does both of those things. It makes a substance that's cytotoxic that will cause diarrhea, and it penetrates the mucosa. Salmonella just penetrates. Let's talk about the history that's taken when somebody comes in with diarrhea, because this determines the, this might help determine the severity and help us assess the risk of complications. One thing we're going to ask first is, what medications is the patient taking? We already talked about several medications in this lecture that could affect diarrhea. Antibiotics, laxatives. What ingestions have they had recently that could have been contaminated? Are they eating old food out of the back of the refrigerator? Have they been to a restaurant? Have they been on a cruise? Do they have a fever? Are they vomiting? How frequently? What is the stool character? Is it watery? Is it bloody? And how about the urine output? Do they have oliguria? Have they had recent diet changes? Like, is it a 1-year-old that was just introduced to dairy? Are they on a new fad diet that's all fruit? With regard to assessment, I know you know this from Nursing 1, you're going to assess the mucous membranes, their weight. Did they lose any weight? What did they weigh this week versus what they weighed last week? And is their skin pale, cool, dry? And how are the fontanelles, which we talked about with regard to dehydration already. I want to go to the next page and talk about the treatment, which is an interesting thing that we use these things called oral rehydration fluids. Sometimes they're called oral rehydration therapy. Sometimes they're called oral rehydration solutions. This is all the same thing. And this is substances like Pedialyte and Ceralite and Infolite. And they have physiologically correct amounts of sodium, potassium, chloride, bicarb, and glucose. They rehydrate the child and restore electrolytes and glucose. So the oral rehydration fluids are used for mild and moderate dehydration. If they have severe dehydration, then we have to start an IV. Is vomiting a contraindication to oral rehydration fluids? That's correct. It is not. What you do is you just give them small amounts, like a tablespoon every half hour. It really helps, remarkably. When someone has gastritis and their stomach is very irritable, you put in a big amount of something and it comes back up. But if you just trick the body and put a small amount, it can be absorbent. So it helps. So the rehydration fluids, they help. They enhance and promote the reabsorption of sodium in water. They reduce vomiting. Let's talk about vomiting for a minute. If somebody is vomiting, it's important, like if a child is vomiting, it's important that we do what for them right after to protect their teeth? We brush their teeth. Why? Acid, because the acid can affect their teeth, that's right. So it also greatly reduces the volume loss from diarrhea. And and it reduces the duration of the illness. Those are the 4 benefits of the oral rehydration fluids. If somebody, after rehydration, we can use it as a maintenance fluid therapy. If it's infants, then we can alternate it with breast milk or formula. Question?
Why did you say have to reduce bone loss? You're going pretty fast.
Reduces the duration of the illness. So you can use it as a maintenance therapy, and you can afterward and alternate with breast milk or formula. Alternate it. How about chicken broth or beef broth? Can we use that for rehydration?
No.
No. Why?
Too much salt.
Too much sodium. That's right. Too much salt. So in older children, what we want to do when they're hydrated, we want to go back to a regular diet. We don't go to a clear liquid diet. A clear liquid diet is typically juice and soda, and that's really heavy in carbs and low in electrolytes. That's why we don't use it. We also don't go to a brat diet. Did you guys know about a brat diet?
But we don't go to a brat diet?
You don't go to a brat diet. If you have been on pediatrics and they're using brat diets or clear liquid, then this is where the theory precedes practice. But you should not go to a brat diet. Brat is bananas, rice, applesauce, and toast. And it has been used in the past because people say it's easier on the stomach. But it's not good for them because it's very low in protein, it's low in energy, and it's low in electrolytes, and it's high in carbs. So we don't teach that you should use it. You should go to a regular diet. Questions so far? Yeah? Oh, you sure? Okay, so I want to go on to the intractable diarrhea of infancy. This happens in the first few months of life, and at this point there is no pathogen and it's refractory to treatment. The original etiologic agent is gone, but the diarrhea persists. These kids are malnourished and dehydrated, and because of that, the villi of their small intestine are atrophied. And because they have trouble absorbing nutrients because of their atrophied villi, it's hard for them to bring in enough nutrients to regenerate their villi. So it's a very dangerous thing. So what happens is they make special formulas for them, where the formula, the protein has already been processed so it can be absorbed more easily. They actually have added water to the protein on a molecular level. So that's called a protein hydrolysate. HYDROLYSATE, a protein hydrolysate. And hopefully they can absorb that, and if it does not turn around, they can die from it. Let's talk about nursing care. Of course, we're going to rehydrate and maintain hydration. It might be the nurse, and it might be the caregiver at home. You might be the nurse on the phone with the caregiver at home, and you're going to be educating them on the phone. And you're going to tell them to count the wet diapers or voidings to monitor the fluids that go in by mouth. So in essence, right there, you're telling them to do eyes and O's, right? You're going to emphasize hand washing, as we have discussed. You're going to tell them to count to determine the frequency and the amount of the stool losses. And give ORT in small amounts. And what are you going to tell them about vomiting? Is it a contraindication to ORT?
No.
Right.
And don't go on a brat diet.
Yes. So, when you're in the hospital, you're going to do eyes and O's. You're going to monitor for signs and symptoms of dehydration. You're going to give ORT in small amounts frequently. You're going to look at the skin care. You want to observe the buttocks and the perineum for infection, and change diapers frequently. What about things like Imodium and kaopectate? Can we give that to babies, to infants?
It would stop
Correct.
whoever's trying to get in from getting out.
That's right. We do not give it to them because it can cause an ileus. It can interfere with motility, and they can get ileus. Any questions? Okay, let's go to the next page, which is celiac disease. Celiac disease is also known as gluten-sensitive enteropathy. And what it is it's an immune response to the lining of the small intestine. In the lining of the small intestine, it's an immune response to gluten, or gliadin, which is the protein in gluten. It's also in wheat, barley, rye, and oats. That's how I remember it, with a little acronym of BROW, B-R-O-W. Barley, rye, oats, and wheat. And the inflammation that it causes leads to flattening of the villi. It is a permanent intolerance to gluten. And it's typically noted several months after the introduction of gluten-containing grains. It usually happens between the ages of 1 and 5. And adults can be diagnosed with it. Kids with celiac disease, they have like a bloated abdomen, and since since the lining of their gut is impaired, they have a hard time absorbing nutrients. And so they get a characteristic look of a bloated abdomen and then some skinny arms and legs. And I'm going to pass this around. It is a picture, a classic look of a kid with celiac disease. The clinical manifestations of celiac disease are diarrhea, and there's another word of a certain kind of diarrhea called steatorrhea. Steatorrhea is when the diarrhea is kind of a large, pale, oily, frothy stool that's foul smelling. And they also get bloating, as we discussed, which is abdominal distension. If celiac disease does not get under control, it really it impairs the absorption of nutrients and electrolytes, and it can lead to malnutrition, muscle wasting, anemia, anorexia, failure to thrive, vitamin deficiencies. Then there's this thing called a celiac crisis. And this occurs in very young children. And they get acute, severe episodes of profuse, watery diarrhea. And that can be precipitated by infections or prolonged fluid and electrolyte depletion, emotional disturbances, or dietary indiscretion. Meaning, they had something with wheat in it. I also just want to say regarding clinical manifestations is that you might have with a small child, you might not see necessarily the GI symptoms. You might just see irritability or uncooperativeness or apathy. Because sometimes kids, they might not tell you, and then you just have kind of a moody kid because he's uncomfortable all the time. So the management for celiac disease is a gluten-free diet. And it is nearly impossible to remove all the gluten from someone's diet. Corn and rice are often substituted for wheat. I want to say, if they're not following a gluten-free diet, the intestinal lesions can lead to a lactose intolerance. And that can improve if the gluten is removed from the diet. That can cause intestinal healing. The lesions can heal. There's also an increased incidence of lymphoma with celiac disease, and strict avoidance of gluten will minimize this increased risk. Questions about celiac disease? Yes? Say it again?
You said that lymphoma is increased, so if they decrease the even is there a chance of getting increased lymphoma that will not occur?
It'll minimize that increased risk. Any other questions? Do you have questions over there? You guys have questions? Let's go to appendicitis.
I do have. If a person has irritable bowel syndrome, it's recommended that they don't have corn because it, I guess, gets stuck in the little areas that's already swollen. So this person with celiac disease, they also have swelling. That doesn't affect them, the little corn bits?
A lot of times they make flour out of the corn. Also, you're giving me a premise that I'm not sure about. About irritable bowel.
Flour, like corn, like, that's what you mean, substitute corn for?
Corn and rice as flour, but they also can use corn. I don't know if I could speak to that really about irritable bowel. And we can live without. What does it look like? Right? And where is it?
Right lower quadrant.
It's in your right lower quadrant. Very good. And so it's right by the cecum in the right lower quadrant. And what happens is it is kind of a piece of a part of our digestive tract where it has gastrointestinal mucosa, and it makes gastrointestinal mucosa, mucuses and secretions. Stool could go in and out of it, right? Because it's in the gut. So what happens with appendicitis is there's inflammation of the appendix. And what happens is when somebody gets a bit dehydrated, the fecal matter gets hard, and it can turn into kind of like a stone. And they call that a fecalith. When you hear litho, you're thinking stone. Also, when you hear calculus, you're thinking stone. So you have like a little stone, and it kind of blocks the entrance to the appendix. And when you have the entrance to the appendix blocked, then mucus can't go in and out. So whatever mucus the lining makes is going to get stuck in there and stay in there. And it's going to build up in there, and you already had some stool matter in there. And so when the mucus is being made in the appendix, eventually it gets really crowded in there, and it starts pressing on the mucosa, and then it presses on the walls of the appendix, and the blood vessels that are supplying blood to that tissue get compressed. And when they get compressed into this already compressed tissue, then they can't supply blood and oxygen and nutrients to that tissue. So now that tissue is compressed and it isn't getting oxygen and nutrients. So it gets ischemic, and because it's not being nourished, we can have ulcerations of the epithelial lining. And you have bacterial stool inside the appendix. So now you have a bacterial substance, and you have ulcers in the lining, right? So that is going to make that tissue necrotic. So then what happens? It can rupture. It can perforate. It can go all the way through and rupture. Now you have bacterial contamination in the peritoneal area. So what happens when you have bacterial contamination in the peritoneal area? Did you say sepsis? We're kind of on our way there. Peritonitis. And so I want to show you this picture I'm going to send around. It's from a surgery of somebody that had that. And you can see the purulent fluid in the area, and you can see them poking around looking for the appendix, and then they get it. So I like to pass this around at this time of the lecture. Additionally, I'd like you to take out that handout I gave you with a lot of pages that has the matching on the front, and look for this page. It says peritonitis on the top of the page. Have you guys seen these memory mnemonics before? So I like this one in particular, and I like to talk about that this man has peritonitis, and he has abdominal rigidity. He has rebound tenderness. Rebound tenderness, what is that? It hurts when you let go. You press and they're like, I'm okay, and then you let go and they go, ah, that really hurts. So what happens when they do a surgery like the one that I'm passing around, when they have peritonitis, they'll take a solution that is with antibiotics, and they'll irrigate that whole area with antibiotics. And then after surgery, that rebound tenderness should be gone. And if it's not, you're going to have to call the doctor, the surgeon. I want to go to the next page. And look at the top of the next page where you have appendicitis. I want to talk a little bit about symptoms of appendicitis. Appendicitis can present as periumbilical cramping and abdominal tenderness. And typically that pain goes to the lower right quadrant. And when we get to, we're back on the PowerPoint. And when we talk about that lower right quadrant, there's a spot that's called McBurney's point, right down there. Somebody named McBurney figured out how to describe it and name it, and then he got famous, because now it's known as McBurney's point. And it's right between the anterior superior iliac spine and the umbilicus. Did everybody see this? I feel like this came back on the same side of the room. Did you guys see this? Okay. Thank you. So it's between the anterior superior iliac spine and the umbilicus. Some of the literature says that it's halfway between, and some of the literature says it's 2/3 of the way between, and 1/3 down from the umbilicus. I would not worry about those fractions at all. If you see different fractions, you have to know it's between the anterior superior iliac spine and the umbilicus. Appendicitis can also present as nausea, vomiting, diarrhea, anorexia, lethargy. They might have a stooped posture and kind of walk like this because it really hurts. You'll see that. In fact, when they're in the bed, you're going to allow them to assume a position of comfort, maybe give them a pillow for splinting right there. If they suddenly have a relief from the pain, what does that mean? It ruptured. That's right, it means it ruptured. And then soon after that, they'll have more problems. But in that moment, they might have a release from that pain. Let's talk about diagnosing appendicitis. So you have a person, they're 15 years old, and they have a pain right here. What are you thinking? You're thinking appendicitis. Can you decide that? Okay, so what are you going to do? What would they do? They can do an ultrasound. What would that do? What would it rule out? Okay, that's very good. Well, she said an ectopic pregnancy, but this is two things connected. You're both right, but for different things. We do an ultrasound because they might have stones. We could look at like stones, look for stones in the ureter. Regard to an ectopic, we want to do what? Test.
Pregnancy test.
A pregnancy test. We're going to do an HCG to see if this person is pregnant. What if she says, I never had sex, I know it's not an ectopic, don't do that test? What do? You do that test. could show up as pain right here is ovarian cysts, which you might see in young girls. That's another thing ultrasound or CT can help rule out. So the treatment, what would we do? We're gonna hydrate them. We're gonna put them on antibiotics. And they're gonna have surgery. They're gonna have an appendectomy. Remember that ectomy, think out of me. That's probably the one thing about me that you'll carry through your whole nursing career, that ectomy, that out of me thing, right? So simple, you'll always know it. I wish there was more, I hope there's more, but I bet that one will stick. Okay, so they could also have ice. You could also give them an ice pack for the pain. That could help. So, let's talk about nursing care plans for appendicitis. There's always acute pain. There's risk for deficient fluid volume. Risk for infection. And with any child, you can always do interrupted family processes. Should we give these people a laxative? No, that can be very dangerous. No laxative, because if it's not ruptured, you can cause it to rupture with a laxative. Now the next thing that I want to talk about is Meckel's diverticulum. And the reason I like to talk about it right now is because it happens in the same place in the body and it can be mistaken for appendicitis. Meckel's diverticulum is a remnant of fetal tissue that's almost like a scar that attaches between the gastrointestinal organs, the intestines, and the inside of the abdominal wall. It's like a scar there. And what can happen is as the tissue is peristalsing, it can wrap around it, it can get obstructed by it, so it can be a bad thing. It can ulcerate and bleed and perforate, and it can mimic appendicitis. So these kids, typically happens between ages 2 and 8, and they might have painless rectal bleeding or abdominal pain. This is a picture of 2 to 8. And this is a picture that was taken in surgery. This is when it was before it was taken out. And you can see that's the diverticulum right there. And then this is the surgical piece when it was taken out, and they circled it again to show you what it was. So I'll show you that. Do you guys want a break? Do you want your dinner break?